Thank you. So it's a continuation of what I was talking about, the DORV, the base of the ventricles. DORV also the better understood if you have a good understanding of the base of the ventricles. I will not talk about everything about DORV, but I will focus on mainly on some kind of the debates in the description of DORV. So I will talk about the definition again, and I will talk about what is TOF and what is DORV, and what is the border or margin of the VSD and remote VSD, absent or vestigial outlet septum. What does it mean? Whether it represents a doubly committed VSD or not. And then I would revisit Tau-C big malformation. And then also importance of 3D imaging and modeling in this context. Okay. So DORV, I think everybody now agrees, both great arteries arising entirely or predominantly from the right ventricle. Okay. It is simply a form of ventricular arterial connection. It does not describe the infundibular morphology. A lot of people say bilateral infundibulum. But don't forget, that definition was in 1960s and 1970s, which means that it's outdated concept. Forget about it. DORV, we are not talking about infundibular morphology. It is simply a form of ventricular arterial connection. So therefore, it is not a single morphological entity at all. Okay? That should be clear. They made it clear. Okay. So I will ask you a question. Audience, they can participate to my question. This is the one drawing made by John Abernethy in 1793. I do 3D printing. I find that this drawing is far better than 3D printing. Okay? And then you see that open the right ventricle. This is tricuspid valve. This is the aortic valve. This is a small pulmonary valve. Here you have VSD. Okay? From the left ventricle, there is a hole. Okay? My question to you is that, is this case a DORV or a tetralogy fellow? How many people think it's a TOF? Yeah? 3 people. How many people will think that this is DORV? Okay? So the reason why I'm asking you is the fact that this is the first reported case of so-called double aortic right ventricle. Okay? And then what is in this case is that by infundibular morphology, it is definitely tetralogy fellow. But however, aorta is almost exclusively arising from the right ventricle. Therefore, this case is DORV by ventricular arterial connection. So that's why, if you look at the Bob Anders textbook, and TOF and DORV can coexist. But it's not necessarily coexist. We are talking about different aspects of pathology. Okay? TOF is talking about infundibular morphology and VSD. DORV is simply how ventricle connects to the arterial trunk. Therefore, this question, is this case DORV or TOF? Stop asking this. It is simply an absurd question. Okay? I will talk about the VSD and DORV. The reason why I'm showing you is that a lot of the confusion is made by Dr. Robert Anderson. I have full respect on him, but however, he screwed up this pathology. Why? Whenever the aortic root is overriding the crest of the ventricular septum, it is a cone of shape. It's a space rather than a specific hole. Rather than a specific hole is correct, but is it a cone of space? No, there is no cone of space at all. It's just imagination. Okay, from the picture. And that provides the communication between the chambers. The VSD is the area in here, marked with the yellow arrow, closed by the surgeons to restore septal integrity. Yes, the surgeons are going to make right and left ventricle separate by putting something. Okay, is it the closure of VSD? I will show you this. So this is a 3D model of DORV TOF. So here you have the right ventricle, tricuspid valve, aortic valve, and pulmonary valve. You have outlet septum, subpulmonary obstruction. So I removed the anterior leaflet and septal leaflet to show the VSD better. So what surgeon we're going to do is that stitch this area, green, which is ventricular septal crest in the presence of VSD. And then remove the outlet septum a little bit, and then stitch the patch here. Okay? And then also along the anterior wall of the tricuspid annulus, you're going to do this, and then you patch it. Is it correct, Dr. Kim? Is that how you do the surgery for DORV? Right? So what I'm arguing about is that if I reproduce here in the schematic drawing, this is a septal crest, which is definitely between right and left ventricle. Outlet septum, in TOF and DORV, outlet septum is not interventricular structure at all. It is right ventricular structure. So-called ventricular infundibular fold along the aortic valve leaflet, it is the right ventricle. So therefore, this space is not VSD, is not VSD. Trying to describe the VSD as the surgeon's, the margin, surgeon we're going to put the patch on, that is the beginning of confusion. Okay. What actually surgeons do in TOF even and in DORV is that VSD is not closed, but LV is baffled to the aorta and pulmonary trunk using the VSD margin. Okay, correct? So seeing that, so here is the remote VSD, and then this is the surgeon's baffle actually. And can you describe this as the margin of the VSD? No, no. So I simply declare that Dr. Anderson's approach on this made you confused, and it is simply incorrect. Remote VSD. Okay, so here that echocardiography shows that VSD extending significantly toward the inlet along the septal leaflet of tricuspid valve. Apparently, aortic valve is far away, and then pulmonary trunk here, and then describe rightfully remote VSD. But the problem of remote VSD is that how do we define the remoteness of the VSD from the arterial valves? There's not very good definition. Surgeons describe if the distance between the upper margin of the VSD to the nearby semilunar valve is larger than the aortic valve. And that is called the remote VSD. But however, you need to have more words. So normal aortic valve size. What if aortic valve is very small? You can't use that. So therefore, you need to think about what the size of the normal aortic valve should be to define the remoteness objectively. Okay. But anyway, so I think that everybody will agree that in this, the model, you have open right ventricle, tricuspid valve, you have a VSD here. This is a medial papillary muscle of Lancisi, which means that there is some inlet extension and some outlet extension. Aortic valve is supported by large infundibulum. Outlet septum is deviated to this side, okay? Yeah, by distance, I would agree that this is remote. Okay. And in the short axis is seen from the apex. Here is a right ventricle, left ventricle, pulmonary outflow tract, aortic outflow tract, outlet septum is here, VSD is below here. Okay. So what we can do is that this is a 3D simulation of a surgical procedure. Okay. And then this is in the short axis, you can have the put there. Okay. And then this is the simulation of the outcome of surgery. So you have a large intraventricular baffling of VSD to aortic valve, and LV to aorta is long, but if you shave the muscle a little bit, it will be all okay. Okay. So this is a 3D, the printed model of the same heart, and this is the patch that we gave to surgeon. This will be the final patch orientation. Okay. So what here that the patient had the proper Rastelli operation, even if the VSD is remote, and then this is the post-surgical outcome. Okay. So good. LVOT is long but unobstructed, and a little bit unusual shape of right ventricle to RV to PA conduit, all fine. Okay. So seeing that, remoteness does not mean that it is not bafflable. When you have your VSD a little bit away from the aortic or pulmonary valve, you always need to think about whether it is bafflable to the aortic valve or bafflable to the pulmonary valve. So therefore, my recommendation is that this is all remote VSD. But however, you need to describe that this case is not bafflable to neither valve. This is bafflable to aortic valve, and this is bafflable preferable to pulmonary valve type of things, okay? Don't stop your description as remote. You always made a few more words, preferable to nitro valve, preferable to aortic valve, preferable to pulmonary valve, okay? So remoteness also will be affected by length of infundibulum. So even if a VSD is in a similar location, if you have a long subaortic infundibulum or long subpulmonary infundibulum, VSD is away, okay? So this clearly shows you remoteness is tricky description of the pathology, okay? So AVSD is commonly regarded as remote VSD, but that's not true. Here in this case, AVSD is limited to the inlet ventricular septum and away from the semilunar valves. However, in this case with the AVSD with the TOF, DORV, the AVSD extends all the way to the aortic valve, right? So therefore, this is actually subaortic component of AVSD. So are AVSDs always remote from the arterial valve? No. Okay. Absent of vestigial outlet septum. Actually, that the Professor Anderson changed this after lengthy discussion with me. What it means is that he used to describe the roof of the common ventricular outlet component, however, is divided by fibrous raphe separating, here, this is fibrous raphe separating aortic and pulmonary valve, okay? So then saying, these hearts have the defect in doubly committed location. If you look at this specimen, actually VSD does not go to the pulmonary valve. It is just below the aortic valve. Absence of outlet septum does not define it is doubly committed, actually. Okay. So here's an example. The ORV with the echocardiographic report saying doubly committed VSD. Okay. So here, great arteries arising from right ventricle, there is no outlet septum at all. Because of that teaching, without thinking, echocardiography report is doubly committed. However, if you look at the VSD, is far extending toward the inlet, remote, okay? So when we did this is an echo report, DORV with a large doubly committed VSD, multiple apical muscular VSDs, okay? So this is the MRI short axis. Look at this. So the VSD has the quite significant inlet extension, and both arterial valves are far, far away from the margin of the VSD, okay? In 3D reconstruction, you can see VSD here, aortic valve is here, and pulmonary valve here, no outlet septum, but however, aortic valve a little bit closer to the VSD margin, pulmonary valve away, far away. It is not doubly committed. Okay, so what it means is that, look at these two cases. Here on your left side, this is definitely doubly committed, but however, there is small outlet septum. So this is doubly committed VSD with a small outlet septum. However, in this case, VSD is here, pulmonary valve and aortic valve in fibrous continuity, but VSD does not go to the pulmonary valve. So this is subaortic VSD without outlet septum, okay? Okay, absent or vestigial outlet septum does not mean that the VSD is doubly committed. Okay, so new literature from the new writing from Bob Anderson now emphasize this. Okay, so example is here. I've shown you this VSD is far from, this is a remote VSD with absent outlet septum. Okay, so Tausig-Bing malformation. It's very interesting. I don't know how that the single case report deserved the name, because this is about the single case report, which is this, by famous Helen Tausig and Richard Bing. Okay? Here, open right ventricle. So here is a tricuspid valve. This is the aortic outflow tract. This is a pulmonary outflow tract. VSD is here, and outlet septum is fused to the right margin of the VSD. Okay? So this is a specimen photograph I got from the Yen Ho and the Robert Anderson long time ago. Look at how similar it is, exactly identical. But however, that is not all the case. So this is the similar case in clinical case. So you have an open right ventricle, the subaortic, subpulmonary outflow tract, outlet septum goes to the right margin of VSD, making this the pulmonary valve below above the VSD. Okay? In short axis, tricuspid, mitral, subaortic, subpulmonary, outlet septum goes to the right marginal VSD with the side-by-side great arterial relationship. However, this is a little bit different. So you can see that outlet septum completely parallel with the rest of the septum. What happens is that here you can see outlet septum is free floating and the posterior pulmonary valve is overriding. Okay? So you can see outlet septum does not go to the margin of the VSD, very different from what you see in the Tau-C being original description. But the physiology and other part of the pathology is very similar. Okay? So this is two different one, right? So this is a classic one. This is the actually you see more frequently this type of Tau-C being rather than this one. Okay, so I talked about this one already. So another form of DORV I showed you already. So atrial ventricular malalignment. Hinge point is here, anterior part of the whole ventricular septum is moved away. It is not the pathology of outlet septum. It is the pathology of whole ventricular septum moving away from the usual position of the anterior interventricular group, making mitral valve straddling and leaving double outed right ventricle. Okay? As I showed you, so there is the malalignment this way. Okay? So what it means is that this is the malalignment. So this is completely different from the other forms of double outed right ventricle. What I'm emphasizing is that this one is that not the outlet septal malalignment, it is the atrial ventricular septal malalignment with the septum hinged to the crux cordis, causing anterior medial part of the mitral valve overriding and straddling. Okay? And then usually associated with DORV with subpulmonary VSD because of this. In the context of TGA, closure semilunar valve will be the pulmonary valve. Usually associated with subpulmonary, not subaortic. Typical Tau-C being, there is subaortic stenosis, not necessarily. Okay? So, literature repeatedly described as the Tau-C being malformation with mitral valve straddling. I will tell you, this pathology is completely different from usual Tau-C being malformation. Okay, so DORV with subpulmonary VSD, this is a case that the atrial ventricular septal malalignment. So this is the outlet septal malalignment, which is called Tau-C being. Very different. Okay. Finally, I will spend can I have 2-3 minutes more? Okay. So how does 3D modeling and printing help in management of DORV? It gives you good insight into helps the surgical decision and surgical planning. If I make the really model with silicone or soft material, surgeons can actually practice the surgery on the model we make. So it can be really good for personalized approach to surgery. So I showed you that this is the computer screen simulation, okay? And then we print out that way, okay, as I showed you. But however, so what is the impact? So a lot of people, they try to know the impact of 3D printing and modeling by looking at the ICU stay, the cross-cramp time, and the pleural drainage, etc. It's impossible to prove the impact of 3D modeling by that way. We looked at a little bit differently. We looked at the Osami Honjo and David Barron, and then did this. Show the echocardiography first, and then ask them, how confident are you in understanding the pathology? And then the one observer was here, one observer here. When we show the CT MR images on the screen, one observer went high up, confidence level goes up. When the 3D models are shown on the screen, goes up more, and then when we show the 3D printing, a little bit more, okay? So you can see that there is some individual variation, but it is how that, what the confidence level of the surgeon on the images we show. So another one, another one, another one, another one. So all together is this. Surgeons, when they see the echocardiography, their confidence level was around the 1.5, which is that slightly confident or not sure, okay? When the CT and MR is shown, it became to about to approach to 2, right? Slightly confident. And then if these 3D images are shown on the screen, confidence level goes very, very high. And in some cases, if you saw the 3D printed model, confidence level goes up. It is a matter of confidence level of the operator, not necessarily pleural drainage or type of things, okay? I showed this, but recently, the new colleague, Israel Valverde, began to do this. So not only making this kind of simulation of printing, and then with the graphically designed patch, what happened, what did is that this is the curved shape of the expected final, the shape of surgical patch. What they did was that mathematically flattened the convex one into two-dimensional space. You can do that mathematically, and then print it, and then took that to the surgery, the OR, and then my surgeon trimmed the intraventricular baffle patch using this template, okay? So this is the surgical outcome. Yeah, outflow tract is very angled, but there is nothing more better can be done. It's pretty well done. So this is my David Barron's testimonial. This is pretty interesting. Thank you, everyone, for a beautiful model and template. Case went really well, and the model was a perfect replica. I pretty much used the patch as it was, as you designed, just trimmed off a very small piece at the apex of the patch where it came under the aorta. I did not have to even think about what width or length to make the patch. I could just cut it from the template, which definitely saved time and gives the surgeons confidence. I would say this is a great testimonial, and then I will tell you that this is only the beginning of the new era when the surgeons would not comfortably do VSD closure or baffling without having a template for trimming the patch or baffle. Okay. In summary, VSD, the DORV definition, both great arteries arising either entirely from or predominantly from the right ventricle, period. Nothing to do in infundibulum morphology. In DORV, don't stick to that four classifications: subaortic, subpulmonary, remote, and the doubly committed. Anything happens. Many cases not following the classic descriptions. Be flexible in perceiving and describing the anatomy. Go after the essential modifiers we published a few years ago. Do 3D imaging and modeling whenever surgeons are not comfortable, not confident in the surgical anatomy. Okay? So VSD description, always think about baffle over to the aortic valve, baffle over to the pulmonary valve, or baffle over to neither valve. Okay? And then think about the ventricular volumes when, after the surgery, will both ventricles be large enough to support the circulation. This is the modifiers, and then we listed the many, many modifiers to describe. Thank you very much for your attention.